Okay, well, welcome everybody. I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from what to why. Because when you know why you do what you do, it changes the how. And that changes everything about patient-oriented decisions that we all make every day. All right, this topic review is again focused on evidence-based medicine and specifically the second main step in the process. Okay, remember, evidence-based medicine has been around for a long time. It's been very well accepted, integrated into things that we're doing, but it's a process of how to answer a clinical question for a patient scenario. And so we're on step 2. Okay, or the second A of the 5 A's of EBM. It's okay to listen this out of order if that's where you happen to be. Nothing wrong with that. It's best if you go back to the earlier lectures before this, simply because it builds on itself. And we're going to do that again today on this particular topic review. The last session we broke down step 1, which is how to ask a clinical question and what are the key elements that make up that. We're going to build on that even a little bit further because it has everything to do with how are we going to acquire this information that we need so that we can apply it to the patient care scenario that we're in. Okay, so as a very quick overview, evidence-based medicine, I'm never going to stop talking about it because these 3 elements in balance, when used appropriately, are what make up EBM. So don't forget just about the evidence, but you're in clinical expertise and experience and its limitations. Just because you've gone through training doesn't mean you know it all. I know I don't. Right? So we all need to be engaged in lifelong learning and expanding our knowledge base. And then lastly, those patient-specific factors or preferences. And then, of course, here we are in the 5 steps or the 5 A's of EBM. So the step 1 or the first A is ask. The second one that we're on today, I'm going to dive in a little bit more in depth on, but we're going to draw off of step 1 and add a little bit more to it, which is why I felt like you need to go back and listen to that one if you haven't. But this is how to acquire the evidence. And then once we've found the right papers, we then still have to go and read them and assess them. And that is the appraisal process through a systematic process of how to review the paper and interpret it for bias and overall determine its level of internal validity so that we can externally apply it. So that's the 4th step, which is application to the patient scenario. And then lastly, of the 5 A's, is assessing our own clinical practice to see if the decisions that we made based on the evidence are consistent with the evidence itself. So the reminder, those 4 key elements, the minimum, the essential, right, is PICO, right, patient or the problem, I for intervention, C for comparison, O for outcome, and then the incorporation of T, which is what I would recommend, which is the timing of the outcome, which is different from an acute care environment versus an ambulatory chronic care outpatient environment. Some people supplement that or replace that with a type of study. Again, that's not the most common that you see reported in the EBM literature, but it is discussed by some groups and specialties. And then lastly is the setting that you're in. Again, is this hospital? Is it clinic? Right? Are you in a different environment, wilderness medicine? Like all of those things drive the context for the type of question that we're asking, which then directs us towards the type of evidence that we need to be going to look for, right? So there are a number of databases out there that offer a format for allowing us to search by those elements. I've listed a couple of them here. Some of them are easier to find and easier to use. I would say TRIP is probably the easiest one to see that. Cochrane, but TRIP, Embase, it's again, if you have access to those, they allow you to use some elements of that format, but TRIP for sure is probably one of the more useful tools utilizing this format. And this is just an example of the page there. Again, these variations will occur as updates are made and things like that. But you can see here on the database there's a PICO tab where you can then fill in, and they give you these examples for each of the components. Now, they don't include the T and the S, but again, it gets you to the basic fundamentals if you like to search and review things like that. PubMed used to do that as well. It's sort of fallen out. I have a difficult time finding it and using it anymore. Most people end up using mesh terminology and their advanced search features. But again, this can be very helpful as you're doing things. When you look at, again, this is Cochrane. You can see it. You have to kind of dive in a little bit further into their clinical content library here in the advanced search function. You can see that they have a PICO-based search modality. And again, they try to break down the 4 main elements there so that you can they kind of give you the structure of how to fill in the blanks. Not as straightforward as TRIP, but it still works. And of course, is searching the Cochrane library itself. So we need a clinical question in its proper format with the elements in there so that we can then identify the terms that we're going to use in the search strategy. And so you may remember this from the previous topic review where I was covering the first step, where this was looking at a clinical scenario of STEMI in older patients over the age of 65, whether we use of aspirin, initial load followed by daily aspirin versus placebo, and its overall impact on all-cause mortality. And I talked briefly about the key words because we might use one word, but a paper's title and or abstract might use a different type of terminology. And it's important for us to consider searches that are geared around text words versus thesauruses, or if you're like in PubMed where you use mesh terminology, and when you apply certain rules to the word, the system knows, consider all of the terms inside of that particular term that's associated with some mesh terminology. That then guides us to the type of evidence. We always want to pursue the best available evidence. So again, you have different question types: diagnosis, prognosis versus etiology, quality of life, behavior, and then the various formats that we might use, again, that break up the elements. And I've kind of covered those in the previous one. Well, that directly influences the type of papers that we want to see. And the search engines that we're going to look at, I'll give you some practical examples here in just a minute. You can click on some of the filtering or search tools inside those engines, and it will drill down and allow you to see results in different perspectives based on what's available and how it's organized. Some search engines organize it a little bit easier and better than others, but you just need to recognize that those tools generally do exist, especially for some of those main databases. Now, as we go and search, there's also different types of databases out there that have different types of literature that can help guide us to that next step. So the first one in that list of resources in the literature are primary literature resources. This is where the original data usually resides, right? The actual studies. These databases are housing that original study information, okay? And these are the 4 probably most common databases out there. CNOL, which represents kind of nursing, allied health, occupational health, psychotherapies, those kind of, and physiotherapy services. MBase is more of a European, specific a little bit more for emphasis on drugs and pharmacology. It's very similar to the Medline or PubMed. PubMed being the US-based database covering all kinds of things, not just humans, but also animal data, and it can extend beyond just pharmacology, drug therapy interventions, biologic agents, diagnostic tests, all those things. It's fairly exhaustive. In fact, sometimes too exhaustive, and it's overwhelming to try to sift through the results that sometimes come out of that. Just to be honest, I'm sure that any of you who have ever done a PubMed search, you can find yourself very overwhelmed with how to narrow some of that down to find what you're looking for, but not miss the key piece. And then Cyclit down here at the end here is more, again, psychiatry, psychology related focuses. So the database and the primary literature sources that you go for may be influenced by your background, what you do and your role in healthcare. And so that's appropriate, or the question that you're asking. Secondary sources of literature, and again, all of these tables are available at thisiswhy.health. For those of you that are subscribers, subscriptions are free. Encourage you to do that and sign up. If you are listening to the podcast version, then obviously you can't see these, but I'm going through them. But these are all available for download for you to use, implement, and utilize in your lectures if you teach, for studying or whatever. But secondary sources would include databases that take the primary literature and provide some summary, and they are very, very focused on giving you links to the primary literature, right? So they're consolidating that primary literature together. So ACP journal clubs, AHRQ, sources like Clinical Evidence, the TRIP database, UK NICE, EBM Online, Cochrane Library, all of these are pulling together original data and formats and summarizing it in ways that make it more digestible. And why that matters and why you should consider secondary sources is because many times those sources will identify some of the important key studies that you need to be focused on that may answer your clinical question and is appropriate for your setting. And so they can be helpful for that. And then lastly, we have what are called tertiary sources. These are kind of like online encyclopedias, Wikipedias type of environments. Some of them are free, like PubMed resources that many times are not always fully peer-reviewed or always up to date. But Medscape, up to date. Many of these you have to pay for access to. Dynamed, eMedicine. There are some sources out there, but they tend to be generalizations, summaries. They may involve expert opinion. They may also incorporate review articles, which are not the same as a systematic review. They may include other types of data or perspectives or letters that you might not find in those secondary sources or may not necessarily be considered a primary literature source by itself for evidence, if you will. So again, tertiary sources, it's good to be able to identify board exams. For those of you preparing or taking tests, these become identifiers for good questions. Which of the following is a primary source or a secondary source of information? It's good for you to know the type of data and information you're accessing and where to find it. I mean, let's just be frank, guys. All of us, I don't care who you are, how much training you have, and I've been in school for a long time, there's a lot I still don't know. There are still gaps in my own knowledge base, and I fully acknowledge that, and that's appropriate, not only for me to say, but it's appropriate for all of us to say, because it's true. What matters is that we know how to find the right information when we need it. So I still look up doses of medications, and on occasion, depending if it's a drug that I've used in a while, I know where to get that. And if I need a quick summary just because I need it for myself or a reminder of what a disease is or some rare condition, I know where to go get tertiary information that's reputable. But if I need original research, then I also know what database I need to go to if I'm asking a very specific clinical question in my patient care scenario. So just make sure that you keep some of this stuff in the back of your mind. Now, when we talk about searching, because we got to go find the information, we set up those key elements of the question, we consider other terminology, we consider the thesaurus effect, and we're going to talk about that. But if you do text word searching, like here an example, asthma and attack, or cerebrovascular and attack, right? Those include both of those words, okay? So that's text-based searching. Most will utilize these types of things, it's called Boolean language, to expand or narrow in on our searches. Now, in the step 1 lecture that I did, I briefly talked about that. I'm going to show you some examples of that here again, but remember, if you include and, then you are going to narrow down some of the results because it requires the search engine itself to be inclusive of both words. If you do or, okay, then that would be either word, and that would expand the search results because you might get results that only have one word and results that have only the other word, and so that would increase the total amount of words and search results that can be displayed. Well, it's also more work that you have to sift through, but you won't miss it if it's available. And then certainly not can help reduce the amount of search results. And this gets into our search sensitivity and specificity approaches so that we can find the right information efficiently and effectively. Now, thesaurus-based searching is that mesh terminology mentality. And even the addition of codes like this, basically what that does is it allows the other terms linked to that keyword to be included, right? But you've got to know how that program or that search engine utilizes terms like that. Or you have to set up your own search strategy with Boolean language to make sure that you include all of these other terms. So, for example, asthma attack could be status asthmaticus. So if you did text-based searches, asthma attack, you wouldn't capture a paper that had status asthmaticus in its title or abstract. Same thing with cerebrovascular accident and the use of the word stroke, right? So text-based only may not get you there. You have to either use Boolean language or mesh terminology with codes to facilitate that effect. So you, again, makes it broader in your hits and your results. Okay, but the ultimate goal is that you find the right paper for the best available evidence for that patient care scenario. And so when we think about search sensitivity and specificity, that's what all of these, things are being considered, right? So for example, if I'm adding more words to consider, well, then I'm going to make my results greater in number, so I'm not likely to miss it, but that's going to increase my search sensitivity. I'm going to get more results by doing that. And again, using Boolean language like or allows me to consider this word or this word or this word, versus if I want to influence the specificity, again, narrow in on more specific headings or abstracts, then using and or not kind of Boolean language will help narrow in on that. Like if I'm looking for a steroid in the treatment of meningitis and I'm only interested in dexamethasone, I might say only search dexamethasone, not, prednisone, methylprednisolone, not, I would do that so that I don't get hits or search results that factor in those other keywords. And again, that would reduce the number of search results, but I increase the chance and risk that I might miss it. I might miss the best data. And that's just the reality, guys. I mean, you don't have time to sift through every single paper on the planet. And if they gives you 2,000 results, well, you can't read 2,000 papers to try to figure out what the answer to the question is. So you've got to find ways to now get that. Now, some of these search engines realize this problem, especially as the evolution of data continues to rise. Trying to sift through all of these papers to get to the paper that matters is challenging. And so they've added these filters or tools that I'm going to show you here in a minute that can guide you through that. So these are some strategies that you can use. We've already talked a little bit about Boolean language up here. We've briefly mentioned the advanced search, but I'm going to show you an example here in just a second. We have limitations by date, study type, population. Like, don't give me animal data, I only want human data. Only give me data between these time frames in history. You can truncate, which are ways to include other terminology. So like, for example, this term here, card with the asterisks, that would include cardiology, cardiomegaly, cardiomyopathy, because they all start with C-A-R-D. Okay, now if you want that, you would do that. Now obviously you're going to get all of these words. That's going to expand your search results. That may not be applicable. Right? That may be overwhelming. But if you're doing a systematic review and a meta-analysis on a thing, you need to find all the papers that are out there. You can also use quotations, okay? Using that, especially if you're using Google, because this prevents Google from truncating the words. Like it says only that in its search. And then lastly are wildcards, where you use a question mark based on the spelling geographic locations. So hematology is a good example of where you're located geographically in the world influences the way it's spelled. Both are correct. Both may be published, but if you, again, do text word searching, you might miss the other spelling, but you got to know that. And so that sometimes can be a limitation if you're not aware. So looking at TRIP database, I mentioned that as one of these options where you can again do PICO. You can also do advanced searches. Again, I find it to be very actually useful. When I was doing my training at Oxford, we actually tested our ability to find, like our professors knew which papers were the best ones. So it's kind of like on an Easter egg hunt, if you will. And so we would jump on, they'd say, put a timer on and figure out which search engine got you to the paper the fastest. And it was amazing. I mean, TRIP won over and over again. And I have no financial interest in TRIP. I just think it is actually helpful. They tried to organize it in such a way that it is. So for example, when you look at it, they try to put the types of results for a question or topic in different types of papers. So evidence-based summaries, synopsises, systematic reviews, guideline statements, and then even which country that it might be in. It can go on to primary research, and it has these little labels that are over here that give you a visual of the type of information. So it's more user-friendly and visually appealing as you interact with it looking for types. And you can click on those and they tell you how many results are present in those particular areas, so you know what you're getting into. And I find that to be, again, very helpful. PubMed's advanced searching, again, you have to know what you're doing. You have to know how to do it. I'll say it is a little finicky at times. It's not super hard, but you just have to follow the rules. So again here, as you build, they have builders to make it a little bit easier for you. And as you build it and you identify the components, again, you see the Boolean language here. They're helping you with that. That helps to build the search strategy language. Well, you can just type it straight in here if you know the code. That's like being a computer programmer, if you will, and you're telling the system what to do, whereas this mechanism or methodology is helping you to build the proper structure so that it can search out what you're looking for. And so you can keep adding to these things, and then eventually you can search. Now you can then add it to your history and then do multiple searches of the history. again, it's time consuming, very meticulous, but it can be very helpful. And that's what it looks like. See, it tells you here, all right, it did the search based on our question, our PICO question that we did earlier with aspirin and a STEMI. And you can see that there were 1,200 results found. And it says, you got search number 1, and you want to add it to the builder if you do. Okay, so you can search multiple searches in a history and help narrow things down. I wanted to show you here again. This is what it looks like on the main site. Again, some of the designs change over time, but whatever, doesn't matter. It's still the same structure. But you see here again. Here's that number that I reported to you just a minute ago in the history, and of course then we get all the results here that can be overwhelming. But how am I going to sift through 1,200? I mean, I got other things to do. So this is where other tools over here, again, those filtering mechanisms can be helpful at guiding us. So if we click on clinical trials here, you see that it went from 1,200 down to 190. Okay, now I can deal with that, right? It might still take a little bit to sift through these titles as I go down, 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 but I can make it through that eventually, right? So those tools exist. Now, clinical summaries and queries, which is another almost a little bit in the PICO framework idea there of trying to get the type of study, and they try to make it a little bit easier for you here on the scopes and the categories and things that you can use. So some people like the clinical queries because they feel like it's a little bit more, clinically oriented and focused to clinician. Google Scholar, helpful at some level, can be beneficial, but you got to, again, play with some of the types of articles and understand some of the search terminology. Again, avoiding those truncating words so you don't get unlimited results. So you can see here 165,000 results. No offense, but that's not helpful to me. So those are things that we need to keep in mind. Okay, so let's talk about an example, and then I want to show you one last example that I did to kind of show you this process in real time as I did it. But I went through this process as a teaching tool for students and residents because to show them some of these steps being implemented, right? So let's say you're a hospital or internist that's you have both inpatient and outpatient environment. You have a 45-year-old patient with known hypertension, and you did a full workup and assessment, and you determined that their risk for cardiovascular disease is about 25%. Well, that's pretty high. So the question is, should this patient, who has not yet necessarily had a heart attack, but is high risk for one, should they receive a statin? So again, 45-year-old patient with hypertension, the risk factors for cardiovascular disease make them 25%. Should you start a statin? Well, what do we know? Well, we know that the patient's age, that helps, again, to provide some context. Is it primary or secondary prevention? Well, in this case, it's primary. There was no information. I didn't say anything about the patient having had a heart attack, a stent, a stroke. Okay? So what is not relevant, but maybe considered to be relevant? I didn't tell you what gender the patient was. I didn't tell you what type of lipid abnormalities the patient had. I think you probably assumed, just like I would assume and most people would presume, is that it's LDL. But what if their primary problem is hypertriglyceridemia or chylomicronemia? Well, statins might not obviously be even in the question. Why would you even go there? So that, again, provides some context. But obviously, do we want to get too specific or too broad? It can be good or bad, depending on what it is. But in this case, we're talking about primary prevention and in patients with primary LDL elevations. And so does a statin need to be initiated? So what we did here, and what I wanted to show you, is the elements of PICO don't just help you with a search, but when you find papers, you should be taking the papers PICO. Okay, what I mean by that, the paper has its own PICO. Okay, and so that paper's PICO, does it align to your PICO? Right? Do you see enough similarities between them that go, yeah, this is probably the paper I'm looking for. Now, it might not be the exact outcome that you were wanting, or it may not be the exact statin that you were interested in. But remember, statins are not just statins, they're HMG-CoA reductase inhibitors, and you might even have to include the names of all of the statins to find the right paper for your question. Now, the paper was a meta-analysis that includes randomized controlled trials that were statins primarily used for primary prevention, but they reported only results of combined both primary and secondary. So now what do I do? My question was primarily in the context of primary prevention. They're including both, primary and secondary. Well, this is still matching my PICO. The patient population is still the same. The intervention, statin for primary or secondary prevention was the papers. Mine was primary. So can I exclude out the sections that include the secondary prevention? Yeah. What does the primary side say? So I stayed with the paper still. And again, I'm doing this really quick. What I mean by that is, like, you're scanning the abstract to go, is this the right paper for me? And as I'm scanning the abstract, I'm not practicing abstract medicine here, i.e. read the abstract and I've interpreted the paper. That's not appropriate. What I'm talking about is I'm scanning the abstract and the title to say, does this paper's PICO line up with my PICO? And again, I'm not writing all this out. I did this to show the example of the real paper so that people can visualize and have that imagery of why are you doing this process. It's systematic. So that you, when you come back to me, like if I were to ask that question on rounds and you come back with a paper, I want to hear the paper in the context of the patient. And the patient wants to hear the context of the decision you're making in their situation, not somebody else's. Right? So these comparative PICOs become very important to make it more efficient so that you're not reviewing 1,500 papers, but you're maybe only reviewing 5. Okay? So we did this search strategy and the methodology from different databases. So we did Cochrane Library, DARE, TRIP, and then Google Scholar. And you can, again, you can see, here's the dividing lines here. I'm sorry, I should have made them a little bit darker here. But you can see Cochrane Library, it's not searching everything else. I got 7 results, 1 article found that seemed to line up. These were some of the terms and the search strategies and search terms that were used. So again, you could see that application based on the database's programming language of how it reads things. But look at Google Scholar, 152,000. And out of that, there were really only 2 papers that were found. And that's a lot of work just to find 2 papers. Okay, TRIP, 3,200, again, 6 papers found. So you can see that some databases are finding different results. So again, depending on which database I use or rely on, may influence whether I find the paper or not. And that's why some good researchers, especially those of you that are going to do systematic reviews, meta-analysis, you're going to go through multiple databases with these search terms and search strategies to make sure that you aren't missing one paper that's found in one database but missing in another. And that's what this exercise in part showed me, is that these databases offer different results and have different search strategy, terminology, and methodologies that are used to narrow in. Okay, so now when we did it more in-depth search with PubMed using a very extensive, again, programmed sort of search strategy using that builder. We even did it on PubMed clinical queries and Embase. But look at the results. Very different. Very different. But we're getting down to now key papers that seem to be the ones that are probably going to answer this question in a solid way. And you might go, well, even within, let's say it's all 13 I'm going to pull. Well, that may not still be the right ones. You still have to go through them and do the PICO analysis comparative. And so it basically came down to, these were the 3 most important papers that were identified, okay? And, you know, obviously a meta-analysis and a Cochrane reviews, those are big. So remember, when we think about the pyramid of data that we desire, most people want a systematic review of the meta-analysis, assuming that the papers in there are good, because junk in is junk out. Even Cochrane review will tell you this is junk, not because they didn't know what they were doing, but because the evidence going into the system is junk. Right? That's good to know. There's nothing wrong with that. If the best available evidence is kind of less than desirable study designs or flawed study designs, well, until somebody does a study, which is why we should invest in clinical research and be behind people doing that, this is what we have. But that helped us to narrow in on the most effective papers to answer the clinical question. So I hope that exercise was not only relevant, you could see it implemented in a real way with different databases. Obviously, I did the work and I just showed you what it looks like. You have to go through it. It took a lot longer than what I just explained here. But the reality is that this process takes a while if you're going to do it the right way. And now you can start to see why clinicians learn EBM but don't always do it, because it could take you up to an hour or 2 hours to find something the right way. So that's where these sort of secondary and tertiary sources have evolved, because they're collating a lot of this information, and then they give you access to those links if you want to dive in a little bit deeper, and we sort of just trust that's the right one. I'll tell you right now, just because something is referenced doesn't mean that's the right reference. I have found a lot of things referenced from some of those sources that when you go to that paper is not directly related to what that statement was, or is completely wrong. That's been shocking at times. So I hope that you found the practice of this relevant and what you need to be doing so that you can be an evidence-based practitioner that evolves into an expert, and that your practice is evidence-based, because when we do that, we patient-oriented outcomes the most. So I hope you found this to be useful. For those of you that are not subscribers, or those of you listening to us on our podcast, please consider subscribing. Go over to thisiswhy.health. We have a lot of things over there for you in your free subscriptions. You get access to downloads, deep dives on some content that I go in a little bit more in depth on for those of you that want to dive on some of those topics a little deeper, invitations to live events, Q&As, and things like that. So thanks so much for joining. I hope you learned a lot. Let's move on to the next step in evidence-based medicine. Take care.